Hello, and welcome to the November-December edition of Sepsis Chatter. My name is Sue Von Bossi, and I'm a quality consultant for Registry Partners Incorporated. Today's presentation is called Severe Sepsis and Septic Shock, Crystalloid Fluid Administration, Part 1. The information included in this presentation is based on the CMS Specifications Manual for National Hospital Inpatient Quality Measures. Discharges July 1st through December 31st, 2022, and discharges January 1st through June 30th, 2023. At the completion of this presentation, the attendee will be able to use the current CMS abstraction guidance to know the 3 triggers that will require crystalloid fluids to be administered, calculate the acceptable time frame in which crystalloid fluids need to be administered, determine the target volume of crystalloid fluids to be administered, and recognize acceptable documentation for ordering a target volume that is less than 30 cc's per kilogram. I'd like to perform a quick overview of the data element Crystalloid Fluid Administration. The definition, documentation of initiation of crystalloid fluids within the specified time frame, and complete infusion of the target ordered volume. Suggested data collection question. Were crystalloid fluids initiated within the specified time frame and completely infused based on the target ordered volume? So there's 4 answers to choose from. We have value 1, which is yes, the target volume of crystalloid fluids were ordered and initiated within the specified time frame. Additionally, the target ordered volume was completely infused. Value 2, no, less than the target volume of crystalloid fluids were ordered or initiated within the specified time frame. The target ordered volume was not completely infused. Value 3, the target volume of crystalloid fluids was not initiated within the specified time frame or unable to be determined. In value 4, no, there is documentation the patient has an implanted ventricular assist device, VAD, or documentation of the patient authorized patient advocate refusal of IV fluids. I'd like to review the Crystalloid Fluid Administration guidance. There are 3 triggers to look for when determining if crystalloid fluids are indicated. The first trigger listed is provider documentation of septic shock. Remember that we can only accept MD, PA, and advanced practice nurse documentation when determining if septic shock is present. RN, pharmacist, EMS documentation is not acceptable. The second trigger is septic shock met by clinical criteria. This would be severe sepsis with an initial lactate of greater than or equal to 4.0. And the third trigger, which we had discussed in last month's sepsis chatter, is severe sepsis with initial hypotension. We know that septic shock is a trigger, and there is also specific guidance that defines the acceptable time frame for fluids to be given when septic shock is present. The acceptable time frame that the fluids must be started can be calculated based on the following guidance. The acceptable time frame to administer fluids is 6 hours prior to through 3 hours following the onset of septic shock. In the example below, septic shock is determined by provider documentation at 1 p.m. So the fluids must be initiated at the earliest 7 a.m., which is 6 hours prior to, through 4 p.m., which is 3 hours following the onset of septic shock. The full target volume required, which was the 2100 cc's, was actually administered within the acceptable time frame, as it was started at 3 p.m. and was finished by 5 p.m. When determining the acceptable time frame to initiate crystalloid fluids in the patient with severe sepsis with initial hypotension, we will calculate 6 hours prior to through 3 hours following the onset of initial hypotension and not severe sepsis. Let's do a quick review of the time frame to assess for initial hypotension first. We would look 6 hours prior to through 6 hours following the onset of severe sepsis. In the example below, severe sepsis was met at 8 a.m. So we're looking for the onset of initial hypotension from 2 a.m., which is 6 hours prior to, through 2 p.m., which is 6 hours following the onset of severe sepsis. Remember again, for severe sepsis with initial hypotension, we're calculating the acceptable time frame from the onset of initial hypotension date and time, and not the severe sepsis date and time. In this example, the onset of initial hypotension was 10 a.m., which is within the acceptable time frame for initial hypotension related to the severe sepsis time. So the acceptable time frame to administer fluids is 6 hours prior through 3 hours following this 10 a.m. time. This would be 4 a.m., which is 6 hours prior to, through 1 p.m., which is 3 hours following the onset of initial hypotension. So the full target volume of normal saline in this example was actually ordered at 9 a.m. and it was administered starting at 11 a.m. and it was complete by 2 p.m., which is within the acceptable time frame for this case. Further guidance tells us to abstract the earliest trigger and calculate the time frame from there. This example illustrates how to determine the acceptable time frame when multiple triggering events exist. The MD documented septic shock in the H&P at 1 p.m. on 12/1. Vital signs on the same date, initial hypotension was met at 1:15 p.m. The blood pressure was 89/59 at 12:30, and there was a map of 63 at 1:15. So, which one would be the triggering event in this scenario? Well, since the initial hypotension is met after the onset of septic shock, the earliest triggering event is the onset of septic shock at 1 p.m. The acceptable time frame to administer the fluids, which is 6 hours prior to the onset of septic shock through 3 hours following the onset of septic shock, would be 7 a.m. to 4 p.m. Let's review a scenario that has multiple triggering events. In the ED, the provider documented severe sepsis as a differential diagnosis on 11/2 at 5 p.m. The documented final diagnosis was septic shock at 6 p.m. Initial hypotension was met at 3 p.m. with a map of 60 at 2 p.m. and a blood pressure of 87/55 at 3 p.m. There was an order for lactated ringers at 1,800 cc's over 2 hours that was written at 5:20. This was the full target volume for this patient. The lactated ringers 1,800 cc's was administered from 6:10 p.m. to 8:30 p.m. So here are the questions to think about. What would be the triggering event in this scenario? What's the acceptable time frame to administer the crystalloid fluids? And were the crystalloid fluids administered within the acceptable time frame? So here are the answers. What is the triggering event? The initial hypotension was the earliest triggering event. It was met at 3 p.m. The severe sepsis was at 5 p.m. and the septic shock was at 6 p.m. So those were met later, but the initial hypotension was the earliest in this case. And what was the acceptable time frame to administer the crystalloid fluids? So it would be 11/2 at 9 a.m., which is 6 hours prior to the onset of initial hypotension, through 6 p.m., which is 3 hours following the onset of initial hypotension. So were the crystalloid fluids administered within the acceptable time frame? No, the crystalloid fluids were initiated at 6:10, which is greater than 3 hours following the earliest triggering event, which was the initial hypotension at 3 p.m. I'd like to move on from the crystalloid fluid acceptable time frame and do a review of how to calculate the target volume of fluids to be administered. The guidance instructs us to use the actual or estimated weight in the following priority order: the weight documented within the crystalloid fluid order, the weight documented closest to and prior to the order for crystalloid fluids, weight documented closest to and after the order for crystalloid fluids. When calculating the target volume of 30 cc's per kilogram, multiply the patient weight in kilograms by 30 to get the target volume needed. Just a couple of notes. If the patient weight is documented in kilograms, do not round up the kilograms, but round up the milliliters to the nearest whole number if needed. So 2181.6 milliliters would be rounded up to 2182 milliliters. If the patient weight is not documented in kilograms, you're going to divide the weight in pounds by 2.2. That yields the weight in kilograms. If the kilograms includes a decimal, round the kilograms up to the next whole number, not the milliliters needed. So in this instance, 72.72 kilograms would be rounded up to 73 kilograms. In order for a provider to use an ideal body weight to determine the target volume needed, all of the following must be met. The physician, APN, or PA documents the patient is obese, which is defined as BMI of greater than 30. The physician, APN, or PA documents the ideal body weight is used to determine the target ordered volume. The ideal body weight is present in the medical record. In other words, abstractors should not be calculating the ideal body weight. Additional terms for ideal body weight are predicted weight, dosing weight, and adjusted body weight. Just a few tidbits regarding the ideal body weight. There's no time requirement for documenting the ideal body weight. It can be documented at any time during the encounter, in vital flow sheets, progress notes, procedure notes. If you can find it, it can be used. For conflicting weights and fluid volume needed, as long as all of the required documentation is present in the medical record, use the ideal body weight and the volume based on that. If there is an actual weight included within the crystalloid fluid order, but there is provider documented plan to use the ideal body weight, there is documentation that the patient is obese, and the ideal body weight is included in the medical record, use the ideal body weight and that target volume ordered, rather than the target volume based on the actual weight included in the fluid order. I wanted to review an example of a QNet query that was submitted regarding the ideal body weight. The EDMD documented the plan to use the ideal body weight in his ED note on 9/1 at 8:54 p.m., but no weight was included. Obesity is documented in the H&P the following morning at 5:16 a.m. The ideal body weight is documented in a flow sheet that following day at 9:32 a.m. The crystalloid fluid order and administration includes the following information. The order was written for 1,000 cc's an hour. The measured patient weight was included within the fluid order at 121.5 kilograms, and there is no reference to the ideal body weight. Normal saline, 1,000 cc's over 60 minutes was administered 9:55 to 10:55 p.m. In addition to the 1,000 cc's, another order is written for 500 cc's over 30 minutes. The measured patient weight was included within the fluid order at, again, 121.5 kilograms, and there's no reference to the ideal body weight. The normal saline at 500 cc's over 30 minutes was administered at 11:45 p.m. through 12:15 a.m. So ultimately, the patient received 1,500 cc's of saline only, which would be correct if we were using the ideal body weight of 50 kilograms. So what we did was we asked QNET, is this acceptable? And QNET came back with the response, yes, you would use the 50 kilogram based on the physician documentation indicating the target volume was based on the ideal body weight and that the patient had obesity. So the crystalloid fluids actually passed on this case. I'd like to move on from ideal body weight and address crystalloid fluid administration, required documentation with a lesser volume ordered. So in order to abstract a lesser volume than the standard 30 cc's per kilogram, there are a few requirements that must be met. The first is an MD order for the lesser volume of fluids, either weight-based or a specified volume. The next two requirements that we'll be discussing must be documented within the same source, either a provider note or a fluid order itself. The volume of the fluids to be administered, either weight-based or a specified volume, and a documented reason for that lesser volume. Some of the reasons can be concern for fluid overload, heart failure, renal failure, blood pressure responded to a lesser volume, a portion of the crystalloid fluid volume was administered as colloids. These are not all inclusive. Remember that, in addition, all of the typical general requirements for fluid administration must also be met. The acceptable time frame, the evidence it was actually given, etc. Also, of important note is that some amount of crystalloid fluid at a bolus rate must be ordered and given, and it has to include all of the required documentation for a lesser volume. The provider cannot opt to administer no fluids at all. I'd like to review a scenario where the documentation is not sufficient to accept a lesser volume ordered. In this example, the patient with septic shock at 12/1/22 at 1 p.m., severe sepsis plus lactate of 4.5, but no initial hypotension. The patient weight was 65 kilograms, 1950 cc's, target volume at 30 cc's per kilogram. The MD medication order on 12/1 at 1:30 was 500 cc's lactated ringers over 60 minutes. This was the only fluid bolus that was given within acceptable time frame. It was given from 2 to 3 p.m. on 12/1. Within 3 hours of onset of septic shock, the MD progress note indicates meets sepsis criteria. However, secondary to the significant respiratory distress and continued rails on exam, we will hydrate the patient slowly. We will not be providing her with the 30 cc's per kilo bolus for concerns of worsening her CHF. So the question is, would the documentation suffice to administer a lesser volume of fluids than the standard 30 cc's per kilogram? The physician note did not include all of the required elements to choose one yes. The target volume of crystalloid fluids were ordered and initiated within the specified time frame. Additionally, the target ordered volume was completely infused. While there is an acceptable reason documented for ordering and administering a lesser target volume for this patient, the physician also needed to include in the same note or in the fluid order all of the required information, the volume of fluids to be administered as either a specified volume, 500 cc's, or a weight-based volume, 20 cc's per kilogram. So the order is missing the reason for the lesser volume, and the physician note does not include the planned lesser volume to be given. This is an example of a QualityNet query that was sent. This is acceptable documentation for the lesser volume ordered. So this patient met criteria for severe sepsis with initial hypotension in the ED. The ED-MD documented the following. Due to the patient's ESRD and dialysis, we will be conservative with the IV fluid management and will do stepwise replacement rather than 30 cc's per kilogram IV bolus. In a following paragraph in the same note, the MD documented the patient's BP responded very well to a total of 1,000 cc's of IV fluids. Of note, there was no alternative amount planned in this note, only the fact that 1,000 cc's total was given and the response after that. The NaCl over 30 minutes times 2 were ordered and administered per the MAR during this time period. For this scenario, the question is as follows. Since the MD did not document the alternative lesser volume planned, only what was given after the fact, does this fail the data element? The answer is no. The documentation that states the patient's blood pressure responded very well to a total of 1,000 cc's IV fluids appears to suffice for the physician documentation requirements, volume, and a reason. Therefore, with the order and the documentation that the fluids were administered, it appears to suffice to select value 1, yes. Lastly, I just wanted to go over calculating the target volume of crystalloid fluids that are within the 10% of the 30 cc's per kilogram. Crystalloid fluids ordered within the 10% of the 30 cc's per kilogram volume is acceptable. Remember that there's no provider documented reason needed. And also keep in mind the order needs to indicate the target volume, even if it's 10% less than the 30 cc's per kilogram volume. An example would be the patient weight of 70 kilograms. The calculated target volume would be 30 cc's times 70 kilograms, 2,100 cc's. Then in order to calculate within the 10% of this full target volume, you would take the 2,100 cc's, multiply it by 0.9, and that will give you the 1,890 cc's that would be needed that would fall within that 10%. So the MD order that goes along with this example is lactated ringers 1,890 cc's over 2 hours. This is acceptable since the volume ordered is within the 10% of the 2,100 cc's full target volume at 30 cc's per kilogram. Again, we don't need a reason for this. Well, we've come to the end of the presentation today, and I wanted to go over a few takeaways. So always refer to the current CMS abstraction guidance. Know the 3 triggers to determine if fluid administration is needed, and always use the earliest one if multiple triggers are present. Keep in mind that the acceptable time frame for initiating fluids when initial hypotension is the earliest trigger is 6 hours prior to through 3 hours following initial hypotension. Using the ideal body weight for calculating a target volume of fluids has a unique set of documentation requirements that need to be met. And lastly, if a lesser volume of fluids is administered, know what specific documentation is acceptable to count those fluids during abstraction. So this concludes this month's sepsis chatter. Please note that this is part 1 of crystalloid fluid administration that focused on triggers, calculating target volumes, determining acceptable timeframes for administration, and certain scenarios that require a specific documentation to accept the target volume ordered. The next sepsis chatter will focus further on orders, determining if and when crystalloid fluids were administered, and how to calculate the end times. Please refer to the resources listed for further information related to the SEP1 measure. The Specifications Manual for National Hospital Inpatient Quality Measures, Volume 5.12 and Volume 5.13. The Sepsis Alliance, and also QualityNet question and answer tool. Thank you so much for attending today's Sepsis Chatter, and happy abstracting!